Thank you very much indeed, Fiona. Let me be the first to say you are a silken-tongued flatterer. But it's interesting how both ministers have referred to frustration with the pace of change, and I share that frustration. But in thinking about today, I thought it might be helpful just to actually take a step backwards and see just how far we've come in the time that rare diseases have been an issue. And if you cast your mind back to 2004, just a decade ago, in January, the Rare Disease Task Force held its first meeting in the offices of DG Sanko in Luxembourg. And that was a group of people who were gathered together really to try and establish the case that rare diseases were an issue that it was important for the European Union to take account of. You know, this was getting rare diseases on the agenda for the European Union, trying to break the image, the perception that rare meant not very many, which meant not very important, which meant that we didn't need to do anything, so therefore, you know, we could carry on with things pretty much as they were. The Rare Disease Task Force set out to demonstrate that rare diseases were a public health matter where there was an EU competence. If you recall the Treaty of Maastricht, that established that the European Commission had a competence in the field of healthcare, but in terms of public health rather than in individual service provision, which remains a matter for national healthcare systems. But in the context of rare diseases, there was demonstrable European added value. It was about creating the critical mass so that rare diseases could be seen in the blizzard of other things that were going on. They became all those tiny little snowflakes, which were individual patients with a rare disease, became aggregated into an iceberg that was sufficiently large to crash into the ship of healthcare that was thundering along in its own traditional way. And we did that because we went from a situation where in most member states, rare diseases were not on the radar for healthcare planners, for policymakers. Services to those affected were very variable. Even within countries, there was no homogeneity of provision, no equality of access. What you got was influenced very heavily by where you lived and how close or how lucky you had been in terms of finding someone who recognized, I know what this is, and I think I know what we might be able to do about it. And that variability, that poor coordination, was the case for many, many millions of patients across Europe. And we felt that that was not a situation that could be allowed to continue. So in the beginning, we had some very, very shallow foundations, but we were beginning to put down roots into the policy and the political community. And in 2008, we ended up, after 4 years' work, with a framework for planning. And in May, the Commission published its communication on rare diseases. And I'm sure many of you have used this to encourage and develop your framework, your thinking, the way in which you create the vision for some of the things which we've been hearing about today. This was the first strategic framework with a pan-European basis, and you can see there, some of the areas it covered. It talked about definition. It established the fewer than 5 in 10,000 prevalence criterion as being the common framework for planning across Europe. It talked about classification and codification. If you look at ICD-10, the International Classification, the 10th edition of the International Classification of Diseases, it's got huge chapters on cancer, on respiratory disease, on neurological diseases. And then there's a chapter that's kind of everything else. And all the rare diseases were kind of dumped in this big amorphous bucket. And if you don't know what you're dealing with, how can you plan? So, still in course of preparation, ICD-11 is going to be able to disaggregate, to empty that bucket of 6,000 different rare diseases and give them each a classification number, give them each a coding, so that you can begin to generate that information about how many people are affected, where are they, what do they need, and improve the planning. There's headings on dissemination, sharing the information, on building networks, and improving access and quality. And we've heard mention already of the notion of centres of expertise. If you don't have sufficient people coming through, then there is no sustainability. You need a critical mass of patients in order to attract physicians, other health professionals, to want to work in an area and to invest their careers in meeting the needs of rare disease patients. So you need that critical mass that comes with a centre of expertise. It talked about orphan drugs, e-health. I mean, Europe is a big place, and not everybody lives next door to a tertiary centre with a dedicated expert team for their rare disease. So you need to be able to get the information about you to the experts, and the information and the expertise of the experts to you and the people who are caring from you, however that's delivered. Let the information, let the samples travel, rather than, unless it's necessary, have patients and families losing time, losing money, and schlepping around between different hospitals, taking a huge amount of their time. It talks about screening and registries and databases. Again, it's important for planning, for service provision, for creating the vision that it is possible and important to invest in the final bit, which is research and development. Because despite the progress, despite the remarkable advances in our understanding of basic biology over the last couple of decades, sadly it remains the case that the vast majority of rare diseases are at best intractable. Many of them are incurable. All of them limit the quality and or the quantity of life for those people who are affected. And the only way in which we're going to change that is through systematic investment in high-quality biomedical research and development, and in frameworks that will allow the translation of the outcomes of that R&D into interventions, into new products, services, support, information, and so on, that will be accessible to patients and provided in a timely and a user-friendly way. So in 2009, we saw the dawning of political awareness. The Council of Ministers of the European Union recommendation on rare diseases was unanimously adopted. All 27 member states said, "Yup, we can do this, and we want to do it." Now, those of you who are familiar with recommendations at European level will know that a recommendation is the lowest form of stick in the legislative armoury. A regulation has to be implemented in its form by all member states immediately. A directive has to be adopted into national law. A recommendation is a moral pressure on member states to act. So it's not so much a stick to beat the legislators with, but more of a twig to tickle them with. But I'm delighted to be able to tell you that your ministers here have proved remarkably ticklish over the last years, and the results of that we've seen announced today. So the commitment was there to develop national plans or strategy on improving services and support for rare disease patients by the end of last year. Well, there's been a bit of slippage. Inevitably, there's been a bit of slippage, and not every member state has managed to do that. But virtually all member states of the European Union either have or are on the point of having some significant plans for implementation. However, it wasn't everywhere that we got that. Dawn Primarolo, who was the UK health minister at the time, I have a letter from her saying we have no need to have a UK rare diseases plan because we've got the National Health Service. If only, you know? So there was still a lot of work to do to convince some people on the ground that, you know, actually having given a commitment, they were expected to honour it. You know, this wasn't something that you could tick the box, feel pleased with yourself, and move on. So, what did we do? I mean, in the UK, we established Rare Disease UK as a multi-stakeholder campaign to work with all 4 governments of the UK to develop the strategy. Because although in European Union terms, the United Kingdom is the member state, of course health is a devolved responsibility, and it is the responsibility of the 4 governments of the UK to ensure that they deliver healthcare to their populations. And Rare Disease UK was set up with representation not just from patient organisations, but from industry, from academia, from the policy community, from the research community, and from anyone else who shared our vision of a goal to improve services and support to rare disease patients. It's a campaign that is run by Genetic Alliance UK, which is the UK umbrella charity for patient support groups for those affected by genetic conditions, most of which are incredibly rare. But you can't join Genetic Alliance UK unless you're a patient organisation. And we wanted to bring all the players into the tent, to get all the ducks in line so that there was no opportunity for divide and rule or for confusion, because everybody was on the same page. And we produced evidence-based arguments after wide consultation that were pragmatic and realistic in their approach. We knew from the start that much as we might wish, you know, there was no tooth fairy with a pot of gold who was going to come along to enable us to do things. There was no going to be no sudden discovery of, you know, billions of quid down the back of the Department of Health sofa. So we had to think about ways in which we could achieve change by working smarter, by making sure that there was integration, there was coordination, that wasted money from delays and ineffective interventions was used to better purpose. So in 2011, we saw some concrete actions. Rare Disease UK published its report, and you can see that there. And I'm sure you've all read it. You've all memorised the 80-odd recommendations that we made in it, and probably could tell me more about it than I know myself. But this was presented to ministers at parliamentary receptions in all 4 UK parliaments, including here, where it was well received as being a positive contribution to the debate. And the unique thing about this report, as I say, it had 80 recommendations, but those recommendations were targeted not just at government, but at industry, at the research community, at patient organisations, at policymakers. It said, this is what we want to happen, this is how we think you should do it, and this is who we think should do it. So there was a way of actually allocating and apportioning responsibility for people to contribute to the overall delivery of change. Because if you don't focus those recommendations and actions on designated individuals, then you can get a situation where everybody thinks it's nice, but nobody thinks it's their job to do it. So we targeted our recommendations. You know, some of them, people came back and said, why have you told us to do this? It's not my responsibility, it's his. So we said, fine, we'll go and talk to him. But it allows for that kind of targeted, focused development work. And that's been a hugely influential thing. And in 2012, some policy proposals emerged. And many of you from the north, at least, will be familiar with the UK-wide consultation on proposals for a rare disease strategy. Now, in UK terms, this was a first. It was the first time that all 4 health departments of the United Kingdom had collaborated on the publication of a consultation on a particular issue. All other consultations about service development had, up to that point, been single nation consultations because of the diverse way in which the health service is organised in each 4 country. But this was in itself a recognition of the unique importance of cross-border collaboration in the delivery of healthcare for rare disease patients. And as you see, we got over 300 responses from patient groups, from clinicians, from academics, from industry, and from many affected individuals or individual professionals. But there was broad consensus and support around the recommendations and the proposals that were contained within the consultation document. So in 2013, we started getting some action across the UK. A year ago today, Earl Howe, the Minister responsible for rare diseases in the UK Parliament, announced the creation of a UK stakeholder forum to advise on the formulation of a UK strategy. And Christine was a member of that forum representing Northern Irish patients. That was a very constructive and engaging exercise, which culminated in November in the publication of the UK Strategy for Rare Diseases, which was announced in Parliament in the House of Lords and at a public launch in Great Ormond Street Hospital. And this, again, was signed off by all 4 health ministers, including Minister Poot, who we've just heard from. Not only was this another first in political terms, it was a first in terms of the degree of cross-party consensus that we achieved across the UK. Because, you know, the makeup of the governments from across the UK represents the whole political spectrum. We have a Labour administration in Wales, a coalition here in Northern Ireland, a different coalition in Westminster, and an SNP in government in Scotland. The strategy contained 51 commitments. And again, the wording is important. They're commitments. They're not intentions. They're not wishes. They're not, well, it would be nice to's, if only. They're commitments, and they're defined as commitments. 31 of these are health service related, and 20 relate to the improvement of opportunities for doing research and development in the rare disease field. They are focused on issues around patient empowerment, on every patient having an integrated care plan, on improving access and things like that. I'm sure you've all read it. In fact, those of you from the north, I have to tell you at this point, there'll be a small test before you're allowed to go home to make sure that you've memorised each one of them. And this provides a framework, a set of promises to patients, and effectively a set of instructions to providers about how the health service and other institutions are going to coordinate and deliver high-quality care to rare disease patients. And this is the first time since the foundation of the National Health Service that there has been this promise to rare disease patients in the UK. So in 2014, now, today, we have moved from a strategy to plans. So each of the 4 nations and each of the 4 NHSs committed to develop implementation plans by today. And you've heard about the progress that is being made to do that, not just here in the north, but also south of the border in the Republic. And those that progress has been remarkably rapid when you think that the strategy was only published towards the end of November. So here we are, barely 2 months later, and we've got a strategy published on the NHS England website, a documentation to appear here in Northern Ireland. In Wales today, they're announcing their plan, which will stand alongside the Welsh cancer strategy, the neurological strategy, and other key elements in the Welsh Health Service. And in the Republic too, there's huge progress and imminent prospect of the plan appearing. But equally, I mean, we've all had government policy documents that have been wonderful. They look fantastic. They're nicely produced. You tick the box, you put them on the shelf, and you move on. Been there, done that, bought the T-shirt, still wearing it. But this plan, the UK Stakeholder Forum, is being reconvened as the UK Rare Disease Forum. You remember the UK Stakeholder Forum was set up to advise ministers. Well, the UK Rare Disease Forum is set up with a specific responsibility to monitor implementation of the UK strategy and to report to ministers every 2 years on progress. That means that there is a real prospect for progress, but it must be monitorable. It must be sustainable and adaptable, because rare diseases don't stand still. New research creates new opportunities. New opportunities create a need for new ways to think and a new way to work. So the UK Rare Disease Forum will be responsible for evolving the plan in the light of new policies, as well as making sure that the health services in each of the 4 home nations set up to deliver and continue to deliver. And I was delighted too that in your speech, Minister, you recognise this need for monitoring and delivering of responsibility, because you have to keep your eye on the ball on this. So that brings us up to today, but there is a vision for the future. There is the International Rare Disease Research Consortium, which promises by 2020 to deliver diagnostics and therapies, diagnostics for every rare disease, and up to 200 new therapies. There's a commitment to patient input to planning and delivery of coordinated service. This is fundamental to good practice, and it's rhetoric on everybody's lips. But we need to make sure that that rhetoric is increasingly translated into practice, so that we have a real voice as patients, as representatives of family, so that we're at the table in ways that give us true partnership. We need to see coordinated, timely, user-friendly, appropriate, sensitive care provided in a sustainable and equitable and an affordable way. We know healthcare systems are under threat, under pressure because of financial resources. But if you look at the experience of rare disease patients, of delayed diagnosis, of rattling round between different clinical specialties, having repeat tests and repeat procedures, of not being diagnosed, of wasting money in the journey to get a diagnosis, of being misdiagnosed, sometimes 2 or 3 times, treated for things you don't have and not accessing things that might help for the condition that you do, then, if we can address some of those issues, we will release resources that will allow for the more effective delivery of service. We need to maintain extensive, high-quality systems for research and development. The advances in things like whole genome sequencing, the development of technologies for screening, for e-health and so on, will create new opportunities to make new discoveries, to generate new knowledge. But the regulatory and health technology appraisal systems need to be fit for purpose. We don't want to get fantastic things coming out from the research community, from industry and what have you, but for the regulators to say, well, we haven't got a system that will allow us to judge the value and the benefit of this that works for the interest of patients. And also there's questions of translation and transition. Fortunately, today, increasing numbers of patients with rare diseases are living longer and longer lives. 20, 30 years ago, for many diseases, there was no need for an adult model of service delivery because sadly those affected didn't live beyond the early years. Now increasingly rare disease patients are living into adulthood and in some cases even into the third age. But we have no history of knowing how to care in an age-appropriate way for people. We have no history of dealing with the comorbidities that come with increasing age. And many of the rare disease patients alive today are the oldest people who have ever been able to live with that condition. So we need to get these translation and transition issues sorted out so people can continue to receive age-appropriate care. So we've had a decade of progress. Let's make the next decade, from today till 2024, a decade of delivery, where those aspirations that we see in the plan can be translated into real, tangible improvements on the ground, so that we can begin to feel, as a rare disease community, our opportunities, our healthcare, our quality of life, our expectations, inexorably moving towards those which those who are not affected, with those who have normal health, take for granted. Now that seems like a worthy cause to me. So, together today, let's commit to make that happen. All of us, from whatever walk of life, from whatever our personal or professional interest is, let's commit to make that happen now for everyone. Thank you very much.